Good morning. Nestled in between all of these clinical talks, I was asked to talk about business. Most things in life are, there's never anything that's completely good or completely bad. And so Louisiana's absolutely terrible access to care for obesity treatment. Pretty much the only good thing I can think of about the fact that patients can't get taken care of in Louisiana is that I know a lot about self-pay. And so that's where my expertise comes from to talk with you about, we've heard about the FDA-approved devices, but then you get down to how am I going to add this into my practice and what are the problems? I do have a lot of disclosures in this area that if my assigned topic was about devices would be pertinent, but I'm going to talk to you about business, and so I think we're safe from my industry affiliations here. So my good friend and respected colleague, Dr. Shariah, just referenced trying to take care of obesity as a chronic disease, and I certainly, I was trained at Charity Hospital in New Orleans, lapping gunshot wounds, and what I loved about surgery was find the problem, fix the problem, the patient gets better, and everything is solved. So it's a little bit surprising but delightful that I'm taking care of this very difficult to treat chronic disease, and I need a 50-year plan, not a one-year plan for how to take care of my patients. It's not what I expected my career would show. And so we are at my site, so at an important academic center like Cornell, they have 3 different specialists taking care of obesity. They have the gastroenterologist that we just heard from, endocrinologist, and a surgeon that work in concert. In private practice at my hospital, I do all of those things myself. And so there's more than one way to skin a cat, and so I provide all those services. But this model of if we're going to take care of the patient for the rest of their lives, even if you're a surgeon, it might be best if you start with less invasive things, preserve all of your options, with the knowledge that you may need to be back and do more invasive things as the patient's life goes on or as their disease progresses. And so that's why Endoluminal might be something to consider adding to your practice. We have this often quoted, especially talking to each other, that, what can we do about the fact that only 1% of patients that would benefit from treatment are getting taken care of, and how can we increase that number and so forth. But I don't know if you've ever done the math on, as a matter of fact, even if everybody showed up and asked to be taken care of, we don't have enough surgeons to address the number of patients that need help with their obesity. And so I would submit to you that that's another reason why we need non-surgical options, is that there are so many patients with obesity in the United States that we cannot operate our way out of this problem. So we need to gather up some other tools. 3 years ago, when the intragastric balloons were entering the United States market, this was the kind of things that the industry folks were showing to potential customers, and they were saying there are 11 million people that would pursue this kind of treatment. Now, this market research is done by soliciting participants and then selecting a sample, and then they extrapolate from the answers that they get from the participants. And so the first time I saw this funnel, the little notes to the side where it says 21,000 people responded and 3,000 people actually were questioned, are my notes to myself to translate how this funnel was created. But nonetheless, there are 60 million potential patients in our country that fall into the BMI range where these treatments are used. And certainly not all of them are interested in pursuing it, but potentially millions of people that would be interested and benefit if you added this into your practice. The other thing is that they somewhat self-select. There are plenty of folks that know what we're up to. They're aware of bariatric surgery, and they want to know what else have you got. My office is trained. It's fairly common for someone to book a balloon consultation with me and begin to chat with me, and I ask them what their goals are, and they tell me that they want to lose 150 pounds, and I sweetly tell them that I can help them with that, but that we need to talk about some other things that I do. And so that's something that you may want to consider. Tell the people that answer the phone to book the consultation, because you don't want the receptionist having a medical conversation about appropriate treatment with the patient, and you don't want potential patients being turned away at the level of their first phone call. So the workflow, it starts with patient acquisition, and this is all self-pay in my practice in Louisiana, as I already said. Patients do have a little bit of attitude, like they've got a lot of money in their hands and they want to be well taken care of. They expect those calls to be answered. Leads decay rapidly, if they don't hear back from you, and so and your local competitors will be happy to take that case, and so you need to take good care of these people and take care of them rapidly. And then there's the conversion, the consultation conversation where you decide what to do, the treatment, and then follow-up. And because you need to advertise for this sort of thing, hopefully getting some successful patient testimonials out of the whole deal. This consumer-friendly focus, I consider myself a physician, not any kind of salesperson, and I never call myself a provider. But there is a customer service piece to this that you may not be familiar with. They are. It's important for anybody that might pick up the phone in your office to know the different devices that are available and be able to answer basic questions like, hey, do you all do this or that? And especially in the beginning when it's new at your practice, you're going to need to educate the people at the office. There's a particular price that the market will bear. This is where I'm about to talk about facility fees shortly. Roughly $8,000 for a balloon, and I have never successfully gotten an endoscopic sleeve gastroplasty paid for by insurance in any way in my market. So about $10,000 for ESG in my Louisiana market. And what happened was, if anybody near you is offering a balloon for $8,000 and your facility says that they're going to need $4,000, for you to do that procedure at the hospital, and we rapidly realized that the facility was taking too high a percentage of the available dollars out of this procedure for us, and so that's when we started to pursue doing endoscopy in our office. So when you're adding up the things you have to build into your self-pay price, you have to buy the device itself, the facility fee, anesthesia, and then you have to pay yourself as well. And there's a lot of follow-up involved with some of these procedures, particularly the balloons. So this is kind of common sense, but when we were putting the endoscopy suite in the office, patients that are coming to see you in clinic don't ever change clothes. And so, figuring out how we were going to navigate the initial waiting room is the same, but endoscopy patients need additional places to change clothes and leave belongings and those sorts of things. Common sense stuff about the place to monitor them afterward and the stretchers. The most important thing, though, has been time, because I'll show you in a minute the biggest expense is the employees in this area. And our biggest challenge, unsurprisingly, every operating room nurse everywhere will be with me on the on-time physician arrival. If I've got an anesthetist and nurses on the clock, I need my docs to show up on time, and I have never cared so much about my partners being either delayed in surgery or having the optimistic idea of how quickly they can get from one place to another. So that's been the biggest problem with calculating these. But in general, when you're figuring out volume in a unit, you can do upper endo in about 15 minutes, colonoscopy in 30. We're not doing ERCP, but I provided that to you for anybody that might be able to have that at their center. I found this in a paper, and I liked that there was what they called an activity factor. So you've got your volume and your cases, and then the kind of X factor, where how long is it going to take you to move the patient in, get everything cleaned up, and go with another one. And so these are all things that you have to experiment a little bit. Referenced already, my most important and my highest price is the personnel. So I'm typically working with an anesthetist, 2 nurses, and somebody cleaning scopes. And that's really been kind of the bare bones, because I've got a nurse watching the people that are recovering, somebody in the endo with me. That's my 2 nurses, somebody cleaning scopes, and then anesthesia. And so that's why, when my guys are 2 hours late, from the hospital coming for endo, and I've been paying a CRNA, the on-time physician arrival has been an important waste of money. The room itself, we were lucky enough to be building a new office building, and so we were able to design a nice big space with all the appropriate things that we needed to provide this service to our patients. But it's been really appreciated by the patients. Like it's a big, comfortable, pretty space. The windows are delightful, and they feel comfortable and safe. And we've all got plenty of room to work, so it's been good. This is the little scope cleaning area. And then, interestingly, another thing that was a challenge was more storage than you think. All of the disposable instruments and medications and snacks for the patients and linen, and this was a piece that when we were just looking at blueprints and mapping out the space, that I don't think we appreciated how much storage would be required. Licenses and other certifications going to differ so much from state to state that I think it's beyond my scope to talk to all of you about what might be needed where you are. We had a pertinent non-compete with a local hospital that had to be navigated. They realized that endo was not a big moneymaker for them, and they just kind of let it go. But you don't want to get into a contest about that, so that's one caution. And whether it's all been worth it. I work with 6 other high-volume bariatric surgeons, and so for us it has been, but for fewer people, that it may not be. So you got to analyze all of this, carefully. It costs us $139 to do an endo. Sometimes, especially a gastroenterologist will try to convince me that volume is the answer. But in fact, whether I do it 15 times or whether I do it 1 time, that's my fixed cost, and I will lose the same amount of money 12 times if I'm not making enough. And we discovered that there are 2 payers that we're better off doing at the hospital than in our little office unit, and you just need to keep an eye on it. It'll be working out for some patients and not for others, and adjust your practice going forward. Of course, the initial outlay for equipment is going to dig a hole for you, but you absolutely have to not only be breaking even, but also paying yourself for your professional time when you're doing this sort of thing. Thank you.